Hello, everyone, and welcome back to the Hobothanga podcast. My name is Crystal Cedino, and I am the Training and Development Manager for the Native Learning Center. I'm so thrilled that all of you are tuning in for yet another episode. These episodes, I feel like, are just getting more and more exciting. I know Cora and I are pouring our hearts into them for sure, and then our wonderful guest as well. Speaking of Cora, my right-hand lady, go ahead, Cora.
Good morning, everyone. I'm Cora Anthony. I'm the Training and Development Specialist here at the Native Learning Center.
Thank you. And we have different guests today, which is kind of cool, and some familiar. So with that, I'm just going to go ahead and introduce everyone. So returning again, we have Keith Nowensky, who is VP of Consultancy. Go ahead and wave, Keith. Awesome. Thank you. And then we have Sean Heberling, who's CFO.
That is correct.
And then last but not least, we have Bart Garber, who's Director of Business Planning and Board of Director as well. So go ahead and wave, Bart. Thank you so much. And he's a returning guest as well. So this is very exciting. Today's topic is going to be the role of healthcare as economic diversification, which I'm really intrigued to kind of get into. So let's just go ahead and jump in there with the first question. And again, welcome back, those of you who have been here, and welcome, Sean, for being on this episode for the first time. We definitely appreciate your time and effort here. But with that, we're excited to see some new faces today and dive deeper into the amazing work that Indigenous Pact is doing. So with that, can you talk to us about IP's work as a healthcare management organization?
Yeah, hello, and so Keith Nowensky again. Thank you, Crystal and Cora, for providing opportunities here and really bringing us back for another session. Really, when it comes to how IP works within tribal nations and alongside tribal governments and tribal nations in the realm of healthcare managed organizations. So what does that really mean? It means we've worked with the tribe to develop a solution to a problem or a solution from a vision to an actually physical something, and then having the opportunity to be alongside to manage that. So in one of the examples, it was a clinic that was collaboratively developed for opioid treatment, and having the opportunity then to partner and be alongside of the tribe to manage the daily operations, to make sure it's running efficiently, effectively for both taking care of tribal and non-tribal members, and then providing value back to the tribe. And that's where we start to kind of go into that whole economic sustainability and platform.
That's wonderful. Thank you for that. Yeah, Sean, go ahead. Continue, please.
Maybe piggybacking off Keith's comments a little bit, I feel like a logical follow-on question to that overview is, why would a tribe consider using a managed services organization? Why would a tribe not just try to build and operate their own healthcare services? And healthcare is a really unique industry that is fairly complex. You've got, unlike traditional industries like manufacturing or retail, patient care, patient privacy, patient empathy, these are paramount considerations. And yet at the same time, the traditional native model, from my perspective, seems to largely depend upon grants to drive their healthcare operations. And what we're trying to do is really get creative, build, staff, and operate unique healthcare facilities that are capable of navigating the intersection of patient care, economic sustainability, and maximizing kind of the blend of activity, return to the tribe in terms of their investment, and again, patient care.
There's an economic element to healthcare and a cultural and social element that intersect in the Native community. there are many native healthcare organizations in the United States that have been lauded and won national medical awards for their management systems. And they've been used as models by healthcare companies globally and all over the United States. In Alaska, we have one, South Central, that's won awards for 2 or 3 years. And they actually have a training program that goes out nationally. I wouldn't call them the Disneyland or Disney World of the healthcare management business, but they're beginning to move in that direction. And the reason is they look at Native people have always looked at tribal members as being the center and core of our societies, and that our interaction and interdependence between us is primary. And it's not just an individual-based society that's out to, make a buck or hook an opportunity or something like that. So that when we look at economic opportunities, we look at the whole and look at the benefit to the organization as well as to the people and the net benefit in healthcare. Indigenous Pact navigates that equation between economic returns and social returns. And I think we really attempt to optimize those and find new ways to expand, as our mission says, expand healthcare opportunities and healthcare access. And we do that by looking at healthcare not just as a social good, but also as an economic good. In the United States, healthcare is a big business. And Native folks, I'm from Alaska, I'm Athabascan, I'm cousin from the Navajos. And for the longest time in our system, we've looked at healthcare as a scarce resource and attempted to try to simply allocate it to as many people as we can with the small budgets and whatnot that we have. So we've looked at it as a scarcity rather than as an opportunity. And Indigenous Pact understands that. It exists. Budgets are short, budgets are small. But for example, many of the most successful Native healthcare organizations are able to multiply their core base budgets by 20 or 30% is a small amount. You hardly have to do anything at all to increase your base budget by 30% if you take care of third-party billings through insurance, Medicaid, Medicare. But some of the more successful ones double and triple their budgets, 140, 150% of their base IHS budgets by better management, better collection systems, and being able to look at healthcare not just as something that people need, but the flip side of the opportunity, so that there are some large Native organizations that create 4 or 5 specialty clinics every year that provides additional services to their people, but by matching that with a sustainable billing program, they're also able to generate revenues that pay for it and other services and growth. And Indigenous Pact is able to bring that model to Indian tribes and those solutions.
So I have a question, and this isn't from what we have, so I don't want to throw anyone off, but should we be treating, healthcare like a business? Because that's been a discussion in our previous conversations. So I'm wondering, is that the right avenue to be going down? Because I know we have to get these things paid for, and, at the end of the day, people need help. That's what it's there for. But yeah, I just kind of wanted to pick everyone's brain on that.
I'll start. Most of the tribal contractors, and certainly the IHS, are organized as nonprofits. But as a lawyer, I can tell you, there are a whole lot of nonprofits that make a lot of money. So nonprofit doesn't mean no profit. Nonprofit simply means you can't give your monies away through dividends or to investors. What you can do is reinvest them. Some of the largest engineering companies in the country are organized as nonprofits, and yet they make more money than many of the for-profit ones. And that's the case with Indian Health Service, direct service organizations, as well as tribal contractors. You can be assured that every tribal contractor healthcare accounting department has to count the numbers. And yes, their first objective is to make certain that the budget is expended as they promised it would be. But they also end up every year with surplus monies, or at least not surplus monies, but non-budgeted third-party recovery monies that they have to put towards something. And so even though they're a nonprofit, they have surplus earnings that they have to do something about. And the best managers plan for that. They have growth plans. They know what kind of clinic needs to grow. It's very difficult to grow your budget. The only way you grow is by bringing in third-party or new revenues that you can then redirect to purposes which are health purposes. So to say you're thinking about it as a business is sort of a left-handed question. You have to start with the premise that nonprofits are not there to not make profit.
So I would probably offer a similar, though somewhat differently worded answer than what Bart has described. And I would say, rather than treating healthcare as a business, we want to treat it as a long-term, ongoing, sustainable activity, because there's a balance, right? The word business, I feel like today it just brings in this negative connotation about, hey, it's all about the cash, it's all about the money. Patient concerns are, lower priority. Staff burnout, not a priority. These things are very important to us, and I feel like by trying to build these long-term sustainable healthcare operations, we're actively evaluating that equation each quarter, each year, and really trying to strike the best balance of return on investment for a tribe, but also really setting the standard for patient care in whatever facility we stand up, and also trying to staff it with the best available professionals, which is getting more and more challenging as the patient population ages.
Oh, great. Thank you for that.
There's
Go ahead. Yeah.
sorry, there's something I would just kind of, if I have a moment here. So just bringing this from the higher conversation down to operations, right? So what does it look like within the clinic? So, those that are listening that may work within healthcare facilities, we have this push and pull between, I'm going to just say Western medicine, trying to get everybody into a 15 or 20-minute appointment time frame, when realistically, the tribe, you bring your family to the visit, right? And it takes an hour, it takes an hour and a half. Both models work. You just have to really understand how on the back end do we staff for it? Do we plan for it? And then how do we create that reimbursement model that's validating or taking care of that longer visit? It can be done. One of the things when I think about sustainability in these healthcare systems, it's really about having the right people performing the right processes in the right place or space, that building that's designed for it, and doing that all aligned with kind of the federal, state, and tribal policies. And when you bring that all together, it's achievable, it's doable.
No, thank you for that. I think that vision, right, and how we can just kind of create the cohesiveness of it all. It is the ultimate goal. So as we kind of keep thinking about, we can't really separate, like Crystal said, the business side and whatnot from one or the other. How can we really use healthcare as a tool for economic diversification? Like, how can we really drive that?
I can give you an example. I mean, for one, when you think about our economies historically, tribes were, and still are, in Alaska, we depend upon subsistence, hunting and gathering. And in some of the larger tribes, or the ones that have larger land bases, that's still true. And in others, even with smaller bases, they've got subsistence farming and sustenance. So that's where we started. But we were also traders between all of our different tribes. And we manufactured and gathered goods that were valuable to somebody else. So we were not unfamiliar with economic processes. Come to the present, and ironically, you know, for 20 years, I ran a government contracting business. When I kind of imagine this in a historical sense, it's kind of comical. I think of a Western movie, and, you know, the cavalry's there and the Indians are outside. And now the Indians are the contractors who manage the fort and provide the goods. So we've found all different kinds of ways to adapt to the economy. Healthcare is one more. Some of the best paying jobs on a reservation are in the healthcare facilities. And you know very well that we publicize immediately the moment we have a native doctor or a native dentist or even a high-level nurse practitioner or something. But those jobs go all the way to the bottom. So diversification, economic development is important to tribes collectively, but it's important to individuals. And I know in Anchorage, where we have, we have a statewide medical facility and a local regional one. Between the two, there are 4,000 to 5,000 jobs. And I know many of my cousins who've worked in that system. And I know people before me who worked up through the IH system and are still in now the tribal contractor system. Matter of fact, I kind of joke with this lady who's a scheduler. I remember her scheduling me when I was 3 years old. I said, "Are you going to work till you're 100? I mean, when are you going to retire?" And she's sitting there at 5:30 at night, still scheduling me for the next time. And I'm 66 years old. And I say, my God, but they are wonderful opportunities, but not just for jobs, but also for contracts. Those healthcare organizations support all kinds of tertiary services. And at Navajo, where I'm on a board, we are actually actively putting a proposal and a plan together to become an air medical service provider. We are going to contract with some national groups, manage our own, coordinate the activities on the reservation, and start taking on air medical emergency hospital delivery services and movements with helicopters and fixed wings. There's buses, there's all kinds of material. Another one of my friends, a young Tlingit guy, he already is a medical supplies supplier to many tribes down the lower 48. These organizations, once they begin to operate on or near reservation, become an opportunity for smart native business people to get involved as suppliers, contractors, and other types of participants in this thing. So they become, in Navajo, where you've got, 13 to 15 large healthcare facilities, there's lots of opportunities there that it generates.
Oh, that's amazing. Again, I don't want to put you on the spot, Bart. Can you give some examples of those like other contracting opportunities out there, just to give, our listeners more of an idea of like what else can be done?
Well, every one of the healthcare facilities has a website. And they don't always, hire internally. You just have to constantly put pressure from the air medical to, frankly, there's lots of contract health right now. Yes, they do bring people in, but a good number of the professionals who work within the system, because as Sean and Keith said, it's difficult to find personnel for these things. They bring contractors in from other locations. If you're a native contractor, if you're a nurse, you can contract yourself in lots of places. You don't necessarily have to jump into the system. And frankly, the sad side of that is that a lot of nurses now are quitting regular jobs, taking contractor jobs that pay 3 times as much. I don't think you're going to get that kind of deal within the IHS system, but that is, the possibility.
Yeah, absolutely. It's an opportunity that's available. So no, that's great. I love it. So with that, let's go ahead and discuss some successes that have occurred. So can you give some examples from your previous work with tribes that have successfully diversified through healthcare?
Well, it would be hard to argue that our crowning achievement, achieved in conjunction with the Muckleshoot tribe of Indians in Auburn, Washington, is not We Care Auburn. So We Care is now seeing, between 400 and 500 patients every single day. This is a highly economic enterprise for the tribe. They've told us it's their second most important economic development. I'm hesitant to give hard numbers to share, information that I'm sure the tribe may not want. But let's just say, this is a tribe that owns a significant casino. So hearing that this is the second largest operation for the tribe, puts that in some context.
Actually, without divulging what that is, up until they created this clinic, the casino and the tribal proper had to supplement their IHS budget to make up for shortfalls when they had budgeted certain types of activities in the multiple millions of dollars. Every year they would have to transfer funds from the general fund that came from the casino and wherever over to the healthcare facility to make up for those. I wouldn't say they were losses. They simply wanted more services and they had the money somewhere else to pay for them. We've made up for that with the We Care Daily clinics multiple times.
No, I love that. Do you have any other examples other than Muckleshoot, of course? Yeah, go ahead.
So some of the things we also want to, acknowledge and think about too is even it seems like a smaller scale, but when Bart started talking about emergency medical transportation, there's the whole tribal non-emergency medical transportation perspective, getting our elders to programs and services on a daily basis. That alone can be sustainable in its own right to employ tribal members as drivers to create that transportation fleet, but yet from a medical perspective, it's getting them to those appointments and back and taking care of people. That is, it's a, I don't want to say smaller scale, but it's a large impact once it's implemented and really rolled out in a proper logistical kind of thought pattern behind it. And then, we look at other tribal nations creating broadband and running fiber as part of their company, which is really, economic development on a great side because it helps to bring, highly, high speed and reliable service, to the every single household. Just a few that I've kind of seen in a few other places. So.
No, I love that. Yeah, go ahead, Cora. No, go ahead.
I was just gonna say, because it reminds me of an episode that we did, like when we were talking about clean energy and how changes in one sector within a tribal community leads kind of to that domino effect of changes in other sectors and creating a job source within the tribe, right? And I'm hearing you guys talk about like economic diversification here with health and whatnot, and that's what I'm hearing. I'm like, Keith, you're talking about broadband. I'm thinking, okay, so if we get a tribe with broadband, that means that we can start implementing like telehealth programs and whatnot, because now they have the reliable connection and so it's kind of like moving away from the idea of like different sectors just doing their own thing and thinking what's the long-term impact if we deploy fiber cables and whatnot, how can that really impact our healthcare industry and whatnot. And it's a beautiful image to kind of like think about in the long term, but that is the goal. So with that being said, right, how does this idea of creating that economic diversification and whatnot impact health equity?
So if you look at the traditional budget for non-Native Americans, the average American is spending a little over $11,000 per year on healthcare. The average Native citizen is spending just over about $1,000 per year. And that's just because the funds have not been accumulated, organized, distributed in a fashion to allow them to spend the money they really need to spend to maintain the same level of health as their non-Native, counterparts. Yep. So the opportunity within native country is such that if a tribe can move outside the IHS system in a certain way, I defer to Bart for the particulars around that. They are capable of delivering services for both native and non-native patients in a way that really offers a two-sided huge benefit. On the patient side, it's the ability to treat primarily those socioeconomically disadvantaged populations that have Medicaid or Medicare coverage in this country, and then on the native side, offer a really high level, standard setting level of care for the native community that's used to that $1,000 a year spend, where we're trying to get them something better than that $11,000 a year spend. And the second benefit on the other side of the equation is just the return on investment to the tribe. By treating high volumes of native and non-native patients, we're able to deliver a really significant economic benefit to the tribe that they can turn around and fund broadband. They can fund roads. They can fund small airports. I mean, they can fund power companies. There's really no limit to the level of creativity where those funds can be deployed, as long as the funds being deployed are for the general advancement of native socioeconomic welfare. You can't go build a casino with some of these healthcare cash returns.
This goes to the discussion that we had earlier, and that is, the statistics are there. It's like 10 to 1 is the deficit in healthcare expenditures in Indian country. Now, we can say we're a heck of a lot more efficient, and so our healthcare isn't 10 times worse. But when you actually look at the outcomes of healthcare statistics, natives are at the bottom of the category of most of them, or near. So that deficit is costly economically and culturally and by health statistics. So we do have to make improvements. Indigenous Pact does it by creating efficiencies in the system as it stands, in increasing returns on billing systems and making certain that tribes are focusing on collecting all the revenue that they possibly can, and that the related payors, whether they're managed care organizations or states through Medicaid systems, are paying appropriately, because in many, many instances, they are not, by multiple millions of dollars. And we have negotiated settlements and arranged for back payments and correction of payments into the future. And this isn't stuff like the lawsuits against the federal government for their underpayment of overhead costs or anything like that. That's another matter. But past that, then when you do plan for expansions of your healthcare system, you do it in such a way that not only expands the services, but expands the revenue footprint. And that, as Sean says, that it's sustainable over time, and that it actually contributes to the growth and the betterment of the healthcare. That is being done, and right now it's a very dynamic time in healthcare. I mean, you've talked about telemedicine, which has been around for a while, but not everybody uses it or can use it. We have been using buses, to go get people. But now, here later this year, Indigenous Pact is going to be driving one of the first mobile clinics for opioid treatment down through Indian country and back up again to Seattle, to be one of the two basically RV mobile opioid clinics that are going to be conducted in the Seattle urban area to serve natives and non-natives. And that'll be one of the examples of, a mobile medical clinic, which I do believe that activity is going to expand beyond opioids. Right now, that's the sweet spot. But I do believe that there is a need to get out to people when they can't get to their facilities. And we're going to probably test that on the Navajo Reservation, which is, the largest geographic reservation in the country. And it's got the largest number of tribal members now after the last census. Over 400,000 Navajo tribal members, and about 2/3 of them live on the reservation, many in very isolated places. So I do believe that this is a time where you're going to be seeing innovative expansion of healthcare, and the challenge will be to expand the revenue base even faster because it's underpaid now. So you have to be doubly innovative.
I love it. I love it. And I think over the last 2 years with, COVID running rampant and so on and so forth, I feel like something that's come through it, if you're trying to find sort of like that silver lining, is that we've noticed that there are tons of creative individuals and there's tons of room for, improvement and development and so on and so forth. So I definitely am looking forward to seeing what else gets put out there and, just as far as, health equity and so on and so forth. But with that, through the series, we've really dug deep on some of the work that IP has done. And so what I'd like to take a moment to do now is, moving forward, what does the future of Indigenous Pact look like?
So I can start off just a little bit from my perspective, the future. There's lots of opportunities. So we are young in our development phase of Indigenous Pact. We are, as you've heard through this series, I'm going to say very engaged, very motivated. We have this entrepreneurial spirit behind us. So we're willing to say, let's investigate it. Not going to say yes to everything right away, but we're going to go do our due diligence, take a look. Is this something we should be involved with? If it is, we'll put our hearts and soul behind it. And when we do our work, for the betterment of tribal nations altogether. If we can take one idea from one tribe that we've helped develop and expand it and share it, that's extremely important to us. I think I look forward to just connecting with even my own colleagues and driving stuff forward, because our energy amongst ourselves is kind of infectious. So I think it's going to be a great future. I think there's lots of opportunities within the global Indian country to move things on a larger scale, to partner with other tribe-to-tribe partnerships to help expand care capacity and everything else along that line.
Right now, as we've discussed the Indian health program nationwide, it historically came from a geocentric, system that had schools or missions and some healthcare services, and then beyond that a clinic, and now a hospital. I was on a teleconference just yesterday, and the tribal people were all, and this was a conference talking about expanding the PRCD, the contract health areas in Arizona. And the tribes were saying, hey, we've got all these tribal members in these areas that are outside our service area that need services, and we need to be able to get to them. And the proposal here was to eliminate the restrictive boundaries of counties for each one of these tribes to be able to do contract health services. And the opposition, not opposition, but the point was being made by the healthcare people from IHS that, gosh, this would increase your service population by 50 or 60,000, and you don't have the money to cover that. And so they said, well, do you really want to do that? And the tribes, who aren't just economic beings, but social beings, are thinking, I've got 50,000 tribal members out there that need help. You're saying our solution is not to bring them in so we don't overspend our money. That is not a solution. That's a statement of a problem. And so one of Indigenous Pact's long-term goals, as I mentioned before, but if you want to talk about the future, is to look at this geocentric system and start looking at insurance type models, looking at the contract health models themselves, cost recovery systems, and other things that we always look at to see how we can increase revenues while expanding services, and see if we can't start with small areas and see if we can't resolve that problem about geocentric restrictive models and find a way that it's profitable and beneficial health-wise for the tribe to expand its scope and service members wherever they may be and others who may come to them. Eventually, such that you might go to, live in California or somewhere and you're not near anywhere, and you're only maybe there for 2-3 months, not like you're a permanent resident and the tribe would take you on, but you could actually walk in, have a little card and say, hey, I need some healthcare services. Right now, they kind of look at you and say, they give you a bunch of letters and then say no or maybe and come back later and you're sitting there with a broken arm. So it's not certain exactly. And more than likely you would get the service with a broken arm, but not with an aching tooth. So we're looking at seeing if we can't use this wonderful system that we have nationwide and unitize it. We know that it can't be done all at once. You have these rational, not objections, but notation that said, hey, you got 50,000 more people that you're going to have to service. You don't have 50,000 more dollars to do it. And work with that type of stuff, because ultimately there are problems. Those people are uninsured or they're underinsured, and see what we can do about modernizing the national Indian healthcare system.
Wow, thank you for that, Bart, and Keith as well. So that brings me to my question: what if one of our listeners or tribal communities is interested in the work from Indigenous Pact and they want to reach out to you guys and make that connection? What's the best way for them to do so?
There's a few people they can call. They're always available. Don Cooley is our representative for tribal relations, but anyone on the screen, if you find them, you can call them and they'll get you to somebody who may have the more specific information that you require. And Kurt Brinkus is always available. If you really have an issue going on, he'll talk to you, and within a little while, he'll have a plane ticket.
The best place to start is probably the website, indigenouspact.com. We do also have a phone number. Currently, it goes straight to Kurt's phone. Our general email contact address is hello@indigenouspact.com. So feel free to reach out.
Awesome.
But you'll be able to find the specific managers and email addresses that if you, and many people in the tribal community know our people. So and just search around and you'll be able to find a way in.
Crystal, you were going to say something?
No, I was just going to say that, I've really enjoyed doing these episodes this last week, and I know this is going to sound so corny, but it feels like Indigenous Pact is kind of like that hope that, healthcare is accessible and available to, to our native tribes, where it sometimes really doesn't feel like it is. And I mean, most of the time it isn't. So yeah, I just thank you guys so much for being here and doing this episode.
Yeah, thank you. I really do appreciate it as well. Do you guys have any final thoughts for our listeners?
Just one on my part. We don't want to take too much credit. We certainly have that upbeat attitude and that can-do attitude, and we want to be able to, breach walls in a way that's comforting to people, not thinking that we're, marauders. There's an entire group of people out there working so hard to make these things work right in IHS and the tribal contractors, in the national and regional policy boards and advisory boards. You got a monstrous system out there. All that we attempt to do is to become facilitators and navigators in that, and be able to be accessible to the individual tribal chairman, the individual healthcare director who says, gosh, I can talk to boards, I can go to the Indian Health Board and they'll put it on the list, darn right. And they'll talk about it all next year, but I need something done, in a few weeks. That's when you come to us, is we can see what can be done now. And certainly it will go hand in hand about what kind of policy change you need regionally or in your local IHS directorate advisory group or in the Indian Health Board. All of that's not inconsistent. It's just that we are action oriented, looking at normally the foot traffic level, and this is Keith's area.
Thank you, thank you, thank you. Keith, Sean, any final thoughts? No? Well, I want to thank you guys for sitting in with us. Like Crystal said, we've had a great week with Indigenous Pact and just kind of learning the ins and outs of the amazing work you guys are doing. And to our listeners, thank you for tuning in for yet another episode of the Hobothia podcast. Please, if you like us, subscribe and rate us on Apple Podcasts, Google Podcasts, Simplecast, and Spotify. And make sure to check out all of our upcoming virtual trainings and webinars on www.nativelearningcenter.com. And we hope you tune in again next week. Thank you.
Goodbye.